Welcome to the COPE-REMS Symposium Series, presented by the University of Washington School of Medicine at Pain Care Live. Today is the first segment in a three-part educational series that will discuss the ins and outs of communicating with patients about the use of long-acting and extended-release opioids for the management of chronic non-cancer pain. Today's session is titled Safe Opioid Prescribing. It starts with effective communication. My name is Dr. Joseph Merrill, and I'm Associate Professor of Medicine at the University of Washington School of Medicine. Joining me today as our featured speaker is Dr. Mark Sullivan, the COPE-REMS Training Program's Executive Director. Dr. Sullivan is a professor of psychiatry who has worked for many years as a pain specialist at the University of Washington Medical Center. This online educational series will serve as an introduction to the more comprehensive content presented in the University of Washington's online COPE-REMS course, which is a 4-hour web-based curriculum that meets all FDA requirements for a course that is REMS compliant. This course is rich with guidance about how to communicate with patients when it comes to prescribing. For example, whether to change a dose level or to discontinue opioid prescribing. We'll provide you with information on accessing the UW COPE-REMS course throughout the course of today's session. Today's session is a live interactive program that allows us to take questions in real time throughout this presentation. I encourage you to send us your questions anytime by typing them in the box located at the lower left-hand side of your screen. I'll now hand the program over to my colleague, Dr. Mark Sullivan.
Thank you, Joe. Welcome, everybody. The topic for today's talk is safe opioid prescribing. It starts with effective communication. Let me talk a bit about what we're going to cover. First, we're going to talk about the problem of chronic pain, and then go into detail about our approach to chronic pain. Specifically, we're going to talk about our web training, COPE for Prescribing Providers, that has now been extended in accord with the FDA REMS on long-acting opioids to be REMS compliant. We're going to talk about not only whether to say yes or no to opioid therapy, but also how to do this, specifically focusing on the importance of upfront goal setting. We're going to also talk about how to say no to requests for opioid therapy, stressing patient safety and overall efficacy of treatment. Overall, we're going to focus on collaboration between the patient and the prescriber as the key to opioid safety. First, a bit about the problem of chronic pain. Historically, pain, and especially chronic pain, has been undertreated because medicine has focused on the treatment of disease as the cause of pain rather than the treatment of the pain itself. However, beginning in the 1970s and the 1980s, there was a successful treatment, both in the US and around the world, to increase opioid treatment of chronic pain as a basic part of cancer care. This was successful. One outgrowth of this was the adoption of pain as a fifth vital sign. The American Pain Society started this idea. The Joint Commission on Accreditation of Healthcare Organizations picked it up. The VA healthcare system picked it up. It was originally an idea to be used on inpatients within the hospital, but it has been extended to outpatients as well. It has taken the very now familiar form of the pain intensity assessment. You'll recognize some of these scales that are used to assess pain intensity. The simple descriptive verbal scale up above, probably the most familiar form to you now is the 0 to 10 numeric pain scale here in the middle, from 0 meaning no pain up to 10 the worst possible pain. And then there's also the visual analog scale where a patient is asked to make a mark on this 10 centimeter line according to their pain intensity. But we have to ask, despite the familiarity of this pain assessment strategy, is pain intensity really the most important aspect of pain, but especially chronic pain? Here we'll see a cartoon that helps me make my point. If you can't read the caption down on the bottom, it says, and with 10 being the highest, you're sure you're only at a 6. See, because the dungeon master is gauging his success at torturing this poor fellow according to what his self-reported pain intensity is. But I think this might underestimate the complexity, not so much of dungeon masters, but of chronic pain treatment. For if we measure pain intensity to determine the success of our pain management efforts, then the goal of pain management is the reduction of pain intensity. And I think that's a far too simplistic idea of what chronic pain treatment is about. So that one answer to the problem of chronic pain has been the answer of chronic opioids. Beginning in the mid-1980s, some clinicians, and I cite here Portnoy and Foley, who had been very involved in the liberalization of opioids for cancer pain, began asking, if opioids are effective and appropriate for cancer pain, why not use opioids for chronic non-cancer pain? By the mid-1990s, the American Pain Society, the American Academy of Pain Medicine, in their consensus statement were saying that opioids are, in fact, a part of the standard care for chronic non-cancer pain. This was picked up on the legal front. In many states, during the mid and late 1990s, we had the passage of what are called intractable pain acts. And these essentially legalized chronic opioid therapy for chronic non-cancer pain without limits on dose or duration. So does chronic opioid therapy work? Well, there have been at least 26 randomized trials showing the efficacy of opioids for chronic non-cancer pain. On average, it's been shown that opioids will provide about a 30% more pain relief than placebo. However, these trials, while they're treating chronic pain, did not look at long-term use of opioids. The trials were the standard length, about 8 to 12 weeks. In fact, the longest one was only 32 weeks, not the multiple months or years of treatment that we're now seeing in clinical practice. While pain intensity was reduced, on average about 30%, there were more mixed effects on function. And these effects tended to be quite short-term and specific concerning the function of a body part rather than the function of the whole person. Another important limitation of these trials is that almost all these randomized trials excluded patients with mental health and substance abuse diagnoses, who we now know are the most common recipients of these drugs. So as I mentioned, the randomized trials are short-term, but there have been open-label follow-up studies, and these really give a mixed picture about long-term efficacy. Up to 50% of patients who are on opioids over 3 months or so stop opioids due to lack of efficacy or side effects. When we look at prospective population-based studies, and there's at least 7 of these, we've seen that opioids, unfortunately, don't promote return to work for injured workers, but retard it. So these are not randomized trials, but they are prospective studies looking at a cohort of patients with new injuries. And in that group, unfortunately, opioids have been shown not to promote rehabilitation and return to work, but they retard that. There is also, unfortunately, the specter of iatrogenic addiction. Can we actually make our patients addicts by prescribing opioids for them? And one historical example of this was portrayed in Eugene O'Neill's play, A Long Day's Journey into Night. It's essentially an autobiographical play about Eugene O'Neill's mother, who developed an addiction to morphine after being treated for a difficult childbirth. In Act 4, Edmund says, "It never should have gotten a hold on her. I know damn well she's not to blame, and I know who is. You are." And he's talking to his father at this point. "Your damned stinginess, and if you'd spent money for a decent doctor when she was so sick after I was born, she'd never known morphine existed." So what this play